that? Okay, lower gastrointestinal diseases. I promised you excitement. I'm delivering excitement now. So, oops, wrong one. These are the various diseases that will be on your exam. There are, of course, lots more, just like in the upper GI lecture. But these are the ones we're going to test you on, and they do cover quite a bit of disorders and diseases of the lower GI. And so bowel obstructions, that's very common, and actually, oddly enough, is deadly. So you want to make sure that you understand how to take care of those patients because you will inevitably have one. Peritonitis, I don't see it as often. I don't think we do as much peritoneal dialysis anymore. It's a lot of more hemodialysis now. So peritonitis might come post-surgical, and it still shows up. It's just not as common. But you still need to know what it is and what signs to look for, especially if you're on a post-op med surg floor. Inflammatory bowel disease. This is not the same thing as IBS or irritable bowel syndrome. So get rid of that. This is inflammatory bowel disease, and we're going to get into it because it has a couple different players under this heading. Diverticular disease, and you will have patients with diverticulitis. It's inevitable. And then colorectal cancer at the end of the lecture. So let's go. Things to pay attention to with your patient. If you guys haven't looked it up, look up the Bristol stool chart. I gave my sister a coffee mug with the stool chart on it. She was very happy. She loves that stuff. I was about to say she loves that shit, and that would be even funnier, but she loves that stuff because this is school and I need to be serious. So, stool, you're going to want to know what are the different types of stools. You're going to look for the melena, so the darkened or reddened stool, the steatorrhea, the fatty stool that's floating on the toilet bowl, in the toilet bowl, not on above the toilet bowl. That would be a spiritual poop. Clay colored, which would indicate a lot of bile in the GI tract, and then the hematochezia, which is more of the like bright red blood on the stool, not necessarily in it, but around it. So you want to be able to identify what all these terms mean. With emesis, we talked about that with the upper GI symptoms and signs. Coffee ground emesis is blood that was in the stomach and then got denatured by the hydrochloric acid, and it comes out looking kind of like coffee grounds, very dark. And then, of course, vomiting blood, hematemesis. There it is. I did it. Pain and discomfort. So you're going to ask them questions. Do they feel bloated? Do they feel gassy? Is it painful? Are they cramping? Does it happen with food, before food, after food? So you want to get this information because this is what the doctors are going to be asking you, or the providers are going to be asking you. Which quadrant is it in where they're having their pain? And you take your best guess. Is it, that upper mid quadrant where the stomach is? Is it left lower, left mid, right lower, right mid, that stuff? And you're kind of keeping an eye out for things that could be referred pain, like, oh, well, the pain is in my belly button. Okay, there's not a lot of stuff that happens there. It might be pain from another region that is referred over to there, or maybe back pain or flank pain, things like that. So these are the types of questions providers will ask you, so we have to teach you what to ask your patients. And then here's the acute abdominal pain. You have the ascending colon on the right side, which goes up, and then you have your transverse colon, which goes across and is sort of behind the stomach. So a lot of pain in the epigastric area could be colon, could be transverse colon, could be stomach. And that's why when you tell providers it's in that area, they might need to get some imaging done to see if they can differentiate between the organ systems in that space. Because I think the pancreas is also there. The spleen sort of comes over there. The liver sort of like scoots into there too. It's a little crowded in that space. And then you have your descending colon going down to your sigmoid and then your rectum, where you drop the kids off at the pool. All right, that's totally appropriate. So we've talked about the diagnostics before. CT scan is pretty standard. And we talk about both oral and IV contrast. You're going to, of course, make sure that if it's going to be IV, that those kidney functions, remember the two lab values you need to know. Make sure you have it written down. Which two is it? Say it out loud so people in your house or your Starbucks think you're crazy. The BUN and the creatinine. Very good. Oral contrast, they take it, is 250 mils. So they have to drink about a cup. Oh, I still have my 49ers cup with me. Yes, I wash it. Thank you for asking. I would say this is more like 300 to 400 mils. So the 250 is kind of like the hospital cup size. Usually you're going to call and make sure that you're talking to the radiologist or whoever, the tech, whoever you're going to transfer your patient off to, and saying, what time is the CT scan set for? I need to make sure I give them this drink 2 to 3 hours prior to the scan so that they are then lit up in the right spots, right? Because you're waiting for it to move throughout the system. You're going to make sure their allergies are okay, that they can manage and handle these types of contrast. And then you want to have an IV that actually works. So diagnostics also can include colonoscopies and sigmoidoscopies. And the colon is visualizing the entire thing. The sigmoidoscopy is really just a small portion. Just sneak it in the door a little bit. And then nursing considerations for both of these is generally that their MPO, 24 hours prior to the test, they don't usually get that intense, especially if they're going to do the prep. So maybe they'll say nothing after midnight, but they're usually starting their Go Lightly prep at like 6 p.m. the night before. So they might be eating, but that food or whatever is getting through the system fast because of that Go Lightly. And you always, when you get onto the floor, you can smell someone who has been taking their Go Lightly, or you go to the med room and there's that giant, 2-gallon container that has the powder at the bottom. It's the Go Lightly powder, and then you fill the whole thing up with water, and then the patient has to drink that whole thing. And it's usually like they drink 2/3 of it throughout the night, and then they can take a break, and then they drink the last like third or quarter before the test, just to see if we can clean them out even more. So their NPO after the procedure, also because we got to make sure that the anesthesia wears off and that they can swallow again. Nothing's going this way, but just because when things get altered, you don't want them to have aspiration because they've been altered. And then, of course, consent. And then the barium enema, we talked about this. Light them up. This is the, series, GI series. This would be a lower GI series that you'd be looking for various issues, polyps. Polyps push in, just so you guys know how to differentiate between polyps and diverticulum. So polyps puts in, so that's inside the GI tract, whereas diverticuli are like out pouches. I look like I know sign language. I'm just trying to do a visual here. So if this is the inside of the GI tract, the polyp is inside the GI tract, right? Oh, there you go. And now the diverticuli is like a pouch that is leaving the GI tract and then coming back in. That's why they say don't take seeds and stuff. And we'll talk about that later. IBD, remember, not IBS, IBD. You can do a series, a lower GI series, to see if you can find what's going on and differentiate between the types of IBD. You can look for colon cancers and you can look for blockages. And then remember, the barium contrast does cause that white stool at the end because it's what lights up the GI tract. So when you take the imaging of it, you can see where there's strictures, where there's problems. And then the nursing considerations would be that bowel prep prior, knowing what the timing is so that you get it right and you can make sure your patient's ready, looking at allergies and meds. And then post enema, you want to make sure that they get rid of that poop that's going to be all white. And you might get them walking around if they can, because that helps them go. or giving them some prune juice, things like that. They might have some PRNs you can give them too. All right, intestinal obstructions. So these are good to know. So I want you to go through and see if you can look up pictures of each of these that helps you understand like the patho behind each of these. So with A, adhesions, think of it as like scar tissue, where things are sort of sticking together because scar tissue was formed there. B, you get this strangulated inguinal hernia where the intestinal tract falls below into like the testicular space, and the muscles can actually cause stricture there. So that's why we, as providers, would have them cough, growing up and even into adulthood to see if it keeps poking down into the testicular sac, into the testicles, to see if we can identify if there's a hernia there or not. C, the ileocecal intussusception. Have you guys ever had those, like, it's almost like a fidget toy and they're filled with water and you try to grab it and it falls out of your hand and like you keep trying to grab it and it just keeps falling? That's what that makes me think of intussusception. It's just like the intestine sort of went back into itself. And D, intussusception from polyps, where the polyps is pulling on it and pulling the intestines down into itself, or the colon down into itself. E, the mesenteric occlusion. So you're looking at the perfusion of that space and how an occlusion could be that it's not getting perfused appropriately. F, you're looking at a neoplasm, so a growth. And then G, the volvulus of the sigmoid colon. It's like this, and then all of a sudden it like spins around and strangulates itself, and this gets, you'll see a picture in just a sec. So make sure you know all those and the wording and what it means and knowing that it just helps you to speak more clearly to providers, etc. And then makes you a better teacher to your patients if you know that terminology. So with bowel obstruction, which is very common, it can be mechanical from cancer, so something is there. It can be a stricture from a previous surgery. Stricture could be, again, adhesions, a volvulus, stuff like that. And you can see in this image, this was clearly a barium image, that's why it's all white, where the colon comes down to a very small point and then moves back out. So you can imagine that the space before that little stricture maybe gets backed up with a lot of stuff. A lot of discomfort can happen there. And then you have your intussusception, again, where things just sort of go back into itself, if you will. Non-mechanical could be partial or complete. It could be related to peristalsis, so the movement of things through the GI tract. And it's very common after large abdominal surgeries. And remember, paralytic ileus is always something that we're looking for, especially in our post-op patients, especially even with patients that have had a lot of narcotics. We're worried about paralytic ileus. And so you want to know what are the signs and symptoms of a paralytic ileus. And maybe it'd be good to write them down here on this slide. So we want to make sure that first we start hearing some rumbling in their belly when we put our stethoscope on them, because every patient you have, you should be listening to their gut. Takes 5 seconds. Just do it. We want to hear that rumble. You want to hear or have them report, I farted. Hey, I'm feeling a little bloated and it's coming out the wrong end. Stuff like that. We're like, yay. Funny enough, we want that for you. And then, of course, I'm not pooping. And so we worry about these things. So paralytic ileus is always something that's in the back of our mind. And then other causes for small bowel obstructions or just bowel obstructions would be sepsis. So you're very sick, some type of infections in your body ravaging you. Electrolyte imbalances can also cause things to kind of stop. And then, of course, narcotic administration. We've talked about that. And if your patients are on narcotics, you generally are giving a Colace or a Senecot or a Miralax, something to keep things moving. Okay, so pictures. You can see all the poop in this pic. Isn't that nice? So animation. So this is all backed up bowel contents. And then here's our little stricture or our blockage, right? and it looks like it's something that pouched out, not in. So it's a diverticulum going out. So diverticulum deflects out. There it is. Diverticulum deflects, polyps push in. Hopefully that helps. If you find another way, let me know. So that way you can kind of see, like, why isn't my patient pooping, or why are they pooping just a little bit at a time? And it's because it takes so much effort to even push anything through that little blockage. So signs and symptoms of blockages. This is very important. Abdominal distension, and you should, when you're listening, you're looking at that belly. Even if the gown is on, you can kind of push and feel, like, ask them, does everything feel okay? Is this rounded belly a normal sign and symptom for them? Is this just their body, or is this new? And again, you can ask people, if they can't speak for themselves, you can ask their family members, are they normally kind of like big bellied, or is this a new finding? Abdominal pain, we want to listen to that. And also remember, the distension could be above where the obstruction is. So you're trying to clue yourself in to, like, okay, I see the distension is very intense when I touch over on the right side. I wonder if the obstruction is somewhere medial, and so everything's backing up on the right side. Just little things that you can help your providers by seeing and knowing and touching and listening. The hypokalemia and hyponatremia, because of the nausea, vomiting. So that one leads to that. The obstipation. Do you guys know what obstipation means? Huh? Do you? If you've ever had a toddler who refuses to drink water, you probably had to deal with this. Obstipation is a really hard, dry stool, which means it's very difficult to push it out and to pass it. And then initially, the bowel sounds might be very high pitched. You might actually even chart them as hyperactive. And then as the obstruction worsens, maybe the bowel sounds start to decrease. Maybe there's a lack of perfusion if things are backing up and things are starting to get distended and pushing on blood systems, in which case you would put hypoactive. So if you listened earlier in your shift and it was hyperactive and now it's hypo, that could potentially be a call to the doc. This is a volvulus. So I struggle a little bit with what is the diseased portion. Well, I guess it's just all disease. Well, it's not diseased, but, like, is the left-sided angry, or is that normal? And the right-sided, is that pale, or is that normal? I actually don't know the answer to this, but I don't think it matters, because what matters is the fact that this thing is, like, spun around itself. And so the blood is getting cut off. This is not a functioning portion of the GI tract. So, let's get this fixed. You can help the providers by being like, something's not right here. And you can use abdominal x-ray to see this. You don't have to actually pull it out of the body. You can actually see this on abdominal x-ray, CT, or even MRI. Okay, so continuing with slow 12, the nursing considerations of a bowel obstruction. Remember that Salem sump that pulls the things out of the stomach so that it decompresses the patient? That's going to be helpful here. So Salem sump, you can probably write that down next to decompression. And you should always associate decompression with Salem sump. Electrolytes, making sure that the electrolytes stay within normal limits, WNL. Fluid volume deficit, this is a big one. You should know this. It's very common that they cannot absorb all the water from their system if the system is faulty or disordered at that time. So you might start seeing their blood pressures going down. You might see them getting more dry, and that can lead to shock, and you'll need to actually put fluids back into the body, and you'll probably have to use IV fluids. And normal saline's fine. It's isotonic. It's a good choice. You're going to monitor the acid-base balances because of the electrolyte imbalances that are potential here. You might need antibiotics because something might grab hold and start growing out, and it's the wrong thing. And you're going to definitely need to know the assessment of the pain, how it feels, where's it at, watching your CBC also. So not just your chem panel, but your CBC as well for your white blood cell count. And then, of course, surgical intervention for any kind of mechanical bowel obstruction. Good. So that last one, so here's some nursing diagnoses that we do: ineffective tissue perfusion, fluid and electrolyte imbalances, pain, fluid deficient. Which one do you think this one is? I'm going to go with ineffective tissue perfusion because it looks like I think all of these actually probably are helpful in describing that volvulus that we looked at. But they also will probably have a lot of pain, like a torsion. It's going to be very painful, and they might end up fluid deficient as well. Okay, so moving on now from bowel obstruction to acute peritonitis. This is usually where the abdominal area is inflamed. Remember, itis, inflamed. Bowel rupture can cause this. So, now you've got poop leaking out into the space of the abdomen. A post-op leak from a surgery could also cause this. And then, of course, peritoneal dialysis. Something can come in through the what is that called? Like the catheter where you would infuse the dialysate. There's a word there, and I don't know if I have it right, but it's the one with all the osmotic pressures and electrolytes all worked out so that it pulls what it needs to out of the GI tract since the kidneys isn't doing it. And then you open the other catheter and you take it out. If you don't know what peritoneal dialysis is, you should definitely look it up. So peritonitis is also called hot belly. That'd be a good name for a band. I called it. So hot belly, and this is a nice graphic to show you what it's about. The one thing I do want to make sure that I point out to you is the abdominal rigidity. Again, if your patient had a nice loose abdomen and all the other assessments, and now you're touching it and they are not a bodybuilder with a six-pack, and now they are rigid, and it hurts to be touched, and especially hurts when you touch and push in and then you let go and they go, ow, that's called rebound tenderness. This is all stuff that you may want to report if it's never been reported to the doc. Remember, a lot of times providers don't put hands on their patients. Surgery might, and definitely all the consultants like OT, PT, speech, they'll put hands on and feel around and do things. But a lot of times doctors are just having conversations, and so they may need to be made aware of this. Okay, so moving on from acute peritonitis is inflammatory bowel disease. Remember, this is not IBS. This is not I have a bunch of pain because I'm a nervous person, or vice versa. I'm a nervous person because I have a bunch of pain. I don't know which one's which. This is more like there's something immune mediated causing problems in my bowels, in my GI tract. So you can put a line right down the middle so you can separate these two. And I tried to use different color and font to make it obvious. Hope you noticed. Okay, so UC, ulcerative colitis. Okay, the other side. They have a lot of diarrhea, and they're probably going to have a lot of pus and blood in their diarrhea. That's very important to remember. You'll have a lot of abdominal cramping, especially before a bowel movement, and then the fluid and electrolyte imbalances are always part of any of these inflammatory bowel diseases. And it can also lead to toxic megacolon. Oh, actually, that's going to be my band name. Forget hot belly. I want it to be toxic megacolon. This is a problem where the colon, because it can't move things past a space, gets bigger and bigger and bigger. And it's also a side effect of like Imodium AD. So if you end up having to take that because you get diarrhea on a trip or something, just keep in mind there's the side effect of toxic megacolon. Toxic megacolon. So that's ulcerative colitis. I'm going to get deeper into these, but I just want you guys to have some notes on this page. Crohn's disease, so this one, Crohn's disease, the stools may contain mucus and pus, but rarely blood, okay? So that's a good distinction to remember. So no blood, probably Crohn's, blood, probably UC. Again, diffuse pain, and same F&E imbalances, so that's not helpful. And Crohn's disease, by the way, is mouth to anus. It could be full of strictures. It could have fistulas. If you don't know what a fistula is, go look it up. It's kind of like a tunneling where the body makes like a spout, essentially, to relieve pressure in an area. It can happen anywhere in the body. So you definitely want to know that. But this is a good slide to remember. You get my drift? All right, so inflammatory bowel disease, again, Crohn's versus ulcerative colitis. And you can put a line down the middle. So Crohn's, you have things called skip lesions, where these lesions can be anywhere within the system, remember mouth to anus. Ulcerative colitis tends to be more in the colon area, so that's why it's colitis. It can be pretty specifically there. And hence, that's where you have blood, right? You'd see a lot of blood. It's in the region. Ulcers make me think of, bleeding. So it's a good way to think of it. All right, let me catch up with y'all. Okay, and also so you understand, inflammatory bowel disease is not necessarily autoimmune, but it is immune mediated, which means that the immune system goes in and tries to correct a problem, like a bacteria, a parasite, something like that. But it doesn't shut off. And I know that seems like the definition of autoimmune, but my nurse practitioner monitor assures me that it is not strictly autoimmune. Okay, so there is a way to kind of quiet these things down and keep them quiet. So if you are diagnosing this, just so you understand what a provider is doing, it's genetic plus environmental. So most likely somebody in your family has had it or has had something similar. A stool culture is indicated to, what is R/O? Rule out infection, because if this is an infectious process, we can treat that easy. But if there is nothing that comes up on that stool culture, then we are probably getting closer to an IBD diagnosis. The barium enema could be helpful. If you notice an elevated ESR, who knows what that means? I think it's like estimated sedimentation rate. So when you pull from the blood and you look at how things fall into, densities of contents of the blood, inflammatory markers mess this up. And so if your ESR rate is, I think, slow, it's because there's a lot of inflammatory markers that are found in the blood. So it's an indication of inflammation. And sigmoidoscopy could also help because if you see all those skip lesions, you're like, sorry, if you see all the ulceration, that's probably UC. You do a colonoscopy and you find all these skip lesions, that's probably Crohn's disease. Again, I'm telling you this stuff because you should understand how providers are figuring out diagnostics and how that leads to their decisions to do different plans of care. Unfortunately, you guys have to know everybody's jobs. Nobody has to know your job, but you have to know all of their jobs so you can protect your license. So when you have a mild case of IBD, you can usually maintain it on this side with the aminosalicylates. So those drugs, the trade names would be mesalamine or sulfasalazine. So you can kind of manage it and keep it quiet. Sometimes they'll have you taking an anticholinergic, like maybe a Benadryl 30 minutes prior to a meal so that it can kind of dry things up a little bit and keep things moving. Flares, however, is a different type of plan of care. So you would not be using your anticholinergics in a flare. So make sure you circle that, okay? Flares, you're going full force with your antibiotics, your steroids. If your steroids aren't, if your body's not responding, you might try some immunomodulators, and those are those UMABs. And then immunomodulators could also be the cyclosporin, the methotrexate, the azathioprine. And then surgical interventions usually are avoided because it'll sometimes come back anyway. So we try to keep the integrity of the tissue that's been diseased and having a flare to the best of our ability so we don't have to pull it out of the body. That's really the idea. And if you get to a moderate or severe inflammatory bowel flare, you're definitely going on the biologics, the UMABs and the MABs. I have a student who told me that she was on Skyrizi and it was working very well for her UC that she has. So you've seen these commercials when you're watching television. Of course, you don't watch television. You're studying all the time. But you've seen these commercials. They're hilarious. They're always like having cookouts and running on the beach and flying kites and stuff. And you're like, oh, thank you, Skyrizi. So you're going to monitor for signs of infection and then keep an eye out for those side effects of headache, nausea, joint pain, and abdominal pain. So you are trying to suppress the immune response and see if you can quiet it down. And I used to think that if my patients were on biologics or just people that I knew were on biologics, we had to be very careful around them because if it's immune suppression, they can get sick easier. But apparently a lot of these newer medicines, they can actually be in society, and the infection control issues are more in the beginning of treatment. And then once they get on the treatment and are solid on it, their immune system bounces back in the right way for I think most people, so they can go to concerts and be around people, and they may wear a mask just to protect themselves, but still, like, that's pretty cool that they can go and live their life now. It wasn't like that in the beginning. We really cautioned them against going out, and now I think we're getting better at treating these. So inflammatory bowel disease, surgical treatments, these are the different indications for surgical therapies. We're worried about cancers. There's a perforation, a fistula. We can't seem to get them off their steroids. That they seem to keep having flares every time we go down and try to wean. Lots of reasons to do surgery. And then the nursing care. So your main job here is looking at an acute flare, because that might be when you have them in the hospital, but you may have them just on maintenance meds and they're there for something else. So you just kind of are understanding the difference between those. So bowel rest is good. We try to get them to stop eating, maybe use TPN if it's going days and days and days and we're like, uh-oh. Because remember, I don't know if you guys remember this, you can go 2 minutes without oxygen, 2 days without water, and then 2 weeks without food. 2, 2, and 2. So clearly oxygen is more important than water is more important than food. But bowel rest, if you're not going to have your patients eating, generally you are probably going to have to intervene after like 3 to 4 days if they are not getting better, and maybe start administering a TPN. It's just something that the providers will figure out. The other thing that you can do is recommend low residue or bland diets. Remember BRAT diet, B-R-A-T. If you don't know what that is, it's like banana, rice, applesauce, and tea and toast. So I guess the B could be bread and banana. Anyway, I do it probably once a year because I get some kind of gastritis and I'm having all these heat issues in my esophagus, and I have GERD type symptoms, and I'm not a GERD person. And so if I start feeling that way, or I'm having a lot of cramping or pain, I might put myself on a BRAT diet for a couple days, and usually it clears right up. And I usually don't need meds. I mean, I might take them just for comfort, but I don't need like the long-term omeprazole meds if I just go on a BRAT diet. And then after a few days, I can kind of test the waters again and introduce noodles or maybe, some vegetables or fruit or something to see if my body can manage at that point. So same with these patients. These are the kind of things you can recommend as their nurse. We definitely want them drinking a lot of fluids, and this is very exciting, salt. Yes, put some salt on everything because they have such a hard time holding on to fluids that we want them to be able to hold on to it as best that their body can. And then any kind of multivitamins to make up for the fact that they haven't been able to eat and probably are deficient in some elements and vitamins. Supporting these patients, helping them find ways to still enjoy life when they can't eat and drink everything that they want to. They might be embarrassed by the weight loss, not, maybe they are having crazy farts or whatever it is. A lot of this is just sort of working through the new plans of care until they can get a couple weeks in and see how their body responds. Because initially treatments will really change things in your body. You might need to hold back on being real social and being around people. And then after a few weeks, you notice those side effects start to subside a bit. And then you can kind of start figuring out what works for you. Support groups are very helpful, very easy. Referrals are always easy. Nurses can make referrals. Remember that. Okay, so after teaching the patient with inflammatory bowel disease about dietary modifications, the nurse determines that teaching was effective when the patient chooses which of the following menus. So take a look at these. So right off the bat, things that are going to be high residue or high fiber are going to be things like, maybe sweet potato, but that's pretty easy to digest. Coleslaw will not be. High fiber brisket is beef. That's going to be high residue. Shrimp with cocktail sauce. Well, the cocktail sauce is tomato based, so it's going to be can be problematic. Corn on the cob is going to be high fiber. Um, Turkey burger might be a good choice. Cheese, okay. Whole wheat, high fiber. French fries, high residue. And an orange is high fiber. Canned pears, actually, oddly enough, the fiber has been broken down quite a bit because it's been sitting in fluid. So it's a better option than like an actual pear. So I'd go with one. Baked cod, baked sweet potato, and then canned pears, kind of a lower residue type meal plan. And which of the following comments made by the patient indicates that additional instruction about the care of a new ileostomy is needed? This is wrong answers only, okay? So look through them. Which one's the wrong answer? Okay, so for number one, preventing odors, actually, you're going to put one of those trees that you can get at the store. You can put that in your bag to help. I'm just kidding. Don't do that. Don't do that. I'm kidding. Do not put anything in the bag. That one looks wrong. Number two, when I change the appliance, I should check for skin for irritation. Nope, that's correct. You should. And that's also the reason why we don't change them every day is because of the skin irritation can be problematic. Number three, I should clean around the stoma with mild soap and water and pat dry. That sounds great. That's a correct answer, just like number two. And then number four, I'll need to alter the appliance opening when the stoma becomes smaller as the area heals. Yes, the amount that you're cutting out on that base that's going to stick to your body and accommodate the stoma, that does need to be checked every time. So number one is our wrong answer / correct answer for this. Okay, so diverticular disease, remember, polyps push in, diverticuli deflect out. So this is an outcropping of that space. And you can see all of those. Yummy, huh? These are good pictures. Okay, so diverticulosis is small herniations or diverticuli of the digestive tract. Diverticulosis, I like to think of is there. You see the SIS is there. They're not necessarily angry or inflamed because you can live with a diverticulosis. And you just kind of like watch your diet and stuff. But when it turns into diverticulitis, tis a problem. Got it? Tis a problem is there. So diverticulitis is one or more of those pouches have become problematic, maybe infected or they're inflamed for sure. Maybe even ruptured and is now leaking into the abdominal space, which then leads to what? Peritonitis. Very good. So you're going to have left lower quadrant pain that just kind of comes on, rectal bleeding, fever, most likely because this is a body and inflammation response to something being wrong. So the body will probably turn up the heat and then a bloating and nausea. Okay. So the treatment for these in mild cases, again, bowel rest, so stop eating for a day or two. They can drink, maybe have some salty broth, that'd be good. But very little treatment and usually resolves fine. For more severe cases, especially when I started off in this business, I'd had a lot more people with diverticulitis. So we usually make them NPO, put them on IV fluids and antibiotics, and then we monitor for that bowel obstruction. Is whatever's happening creating a lot of inflammation in the space that could create an obstruction? And we're also monitoring for rupture and then signs and symptoms of the peritonitis. Pain management is very important with these patients. Surgical intervention is necessary if it ruptures. We have to get them into surgery right away. And you'll probably see that rigidity of the abdominal space. So you go and touch them, you're like, ooh, it was not that hard before, and you are not a bodybuilder, so I might need to call. And then you might notice their pressure's going down or maybe their heart rate going up. So there will be signs. You can call a rapid if you're unclear and see if you can get a bunch of people in the room to like figure it out. And hopefully you're wrong. But if you're right, thank God you called it, right? Don't ever be afraid to call it a rapid. Diverticular disease patient education. I think we're going to have a presentation on this, but just as a side, eat more fiber to prevent the disease because it actually cleans everything as it goes through, scrapes everything out. But you should avoid like the little nuts and seeds and popcorns because those can kind of make their way into those spaces, those diverticuli herniations. It can make it in there and it can even, cause it to perf. Lots of fluids, exercise regularly, prevent constipation so you're not straining. I bet you enjoyed that. That's going to be the cover of Toxic Megacolon, the album. Low residue diet during flares, but when you're maintaining disease, you can eat the higher fiber. But when you have a flare, now you're going to go back to your brat diet and try to loosen up how much fiber you're taking in. Okay, I'm going to just pause for 1 second myself, and then I'm going to come back and we're going to do colorectal cancer. Okay, so focus on colorectal cancer. This is the third most common form of cancer, second leading cause of cancer-related death, the first and most common cancer that leads to death. Does anybody know? Lung. 85% of colorectal cancers arise from adenomatous polyps. Adenomatous. I can't always pronounce the words in this business. Please forgive. But that's referring to the type of cell that is turning cancerous. And it's a polyp. Remember, polyps push in. That's why when we do these colonoscopies, we're looking for polyps and we're snipping them and taking them out of the body. And it's the type of cell line that can create this cancer. Okay, so etiology and pathophysiology. It's more common in men. There's usually a family history, and it gets more risky for you if you're getting older, if you've had colorectal polyps on previous colonoscopies, or if you have some of the IBDs, either the UC or the Crohn's disease. So just remember those. Lifestyle factors that actually contribute to this are all the things we hear about, obesity, physical inactivity, smoking, alcohol, so essentially my college years, and then large amounts of red meat, which luckily society's gotten a little better with this one, but there's still people that eat a lot of red meat. So incidence of cancer by section of colon. So in the ascending colon, so the ascending going up, it's a little bit evenly split between the sigmoid colon, and rectum. So you can see those three are the highest incidence. Transverse, not as much. Descending, not as much. And the cecum, where it comes from the small intestines into the large intestines, is a lower number, but not insignificant. So patho and etiology, we're looking at most common sites of metastasis. So where is this colon cancer spreading to? So clearly bones. Bones are in the region where that might be. Liver, because liver is close by to, a lot of that right-sided liver, that ascending colon is next to the liver. And then lungs and brain, especially if it gets into the regional lymph nodes. Complications that arise from colon cancer are obstructions. So those tumors, or those neoplasms, as they can also be called, can grow bigger and bigger and start pushing on things. Bleeding from those tumors is possible. A perforation where it splits now and starts leaking out into the abdominal space, which then leads to peritonitis. A fistula formation, remember the tunneling, the body always tries to find ways to relieve pressure. So these are all common complications of colon cancer. That was a lot of C's. Common complications of colon cancer. It's called an alliteration. All right, diagnostic studies. So you've got the two, right? You have your gold standard colonoscopy, but you also have one that's a little less invasive called your FIT test or Cologuard test. So that's the fecal immunochemical test. You can do that one at home. So that's what you'll probably teach your patient, is that, hey, make sure you do that test when they send it to you in the mail. Cancerous tumors will bleed intermittently into the colon. However, FIT tests, though they're looking for blood, if it's a non-bleeding tumor, it will not detect it. So these are not 100%, which is why then we go over to colonoscopy as our gold standard. So the entire colon gets examined, and we're looking for those tumors. We're looking for those things that are causing problems. Biopsies can be obtained while they're there. Like, oh, here's the polyp. Let's take that out of the body. We'll send it off to be checked out. And then what should you tell your patient about this procedure and how to prepare for it? Diaper Up. That's going to be the first hit off of the Toxic Megacolon album. Diaper Up. So fit test colorectal is at home. They can do it. They can do it on their own time and space behind a locked door and send off the sample. A colonoscopy, they're going to have to prep and drink all that stuff. And it might be a smaller amount. They might give them more like a magnesium supplement that helps them go really fast. But they're going to be on the toilet all night. So again, diaper up. So here are some pictures of various carcinomas that they found in the colon. Some of them are surrounding the tube. Some are inside. So that's a lot going on. Clinical manifestations of colon cancer. So the left-sided lesions, remember this is the descending tube of the colon. Rectal bleeding, so you might actually see blood in the poop or when they wipe. They might have both constipation and then diarrhea. It could have one or both. And then change in stool caliber, is there meaning like the size of the stool? Especially if it has to squeak by a tumor, it might get pushed down into a smaller sized poop. They might notice that. And then of course, if they're pooping like little slivers at a time, they might feel like they're not evacuating like they used to. So if you start hearing them talk about that stuff, these are definitely things that are potential signs and symptoms and can clue us into something's not right. And then the right-sided lesion are the stuff that's going up as usually asymptomatic, has some like vague colicky pain and cramping associated with it. They may not even mention it. They might find that if they just eat a different diet, it kind of stops and doesn't bother them as much, but in the meantime, the tumor could be growing and growing. All right, so collaborative care, of course, you're going to be sending them to oncology to be dealt with. Chemotherapy is very common plan of care, and then biologic and targeted therapies might also be used. What we're looking to do is block the epidermal growth factor receptors, so that those skin cell growth factor receptors, we might try and block those so that we can keep the tumor from growing bigger and bigger and bigger. Or we might recommend like an angiogenesis blocker, which is going to stop blood from being able to get to that tumor and feed it what it needs. So we've got a couple different ways to try and deal with managing that tumor. We might also choose radiation therapy, which can be done post-op or in cahoots with a chemotherapy or with a surgery. Sometimes they'll do it pre-op to try and see if they can shrink down the tumor a little bit before they go in and cut it out. There's a lot of different plans of care, and it really depends on usually the cell line of the tumor, so that they can make a good decision on the genetics. Like, we know the genetics of these cells will respond to this plan of care. Genetics are coming more into cancer treatments, and we're looking at the genes behind a tumor cell and figuring out, oh, okay, we've understood that people that have received just chemotherapy without radiation didn't do as well when they had this gene in their tumor cell. So you have like a database now that we're working from, and that's where oncologists are getting their plans of care from and consulting with that. Surgical therapy, it's really the only cure. If you cut it out and get it out of the body, great, but then you worry about it growing back. So a polypectomy, you'll go in through colonoscopies and snip those, polyps to see if you can keep it from turning over into a cancerous cell. They can also go in and resect the colorectal cancer, cut it inside of the body during colonoscopy, and then drag it out. If cancer is localized, it can be resected and the healthy tissue will stay and be sewn back together, and lymph nodes will be removed because, that's what we need to do. If it's gotten infected, we got to pull them out. So if they do have this surgery, they may need to have a colostomy for some time after the surgery. And so here are some various sites where the little bud might show up. So depending on where the cancer was and where they had to cut tissue out, They may choose to have poop just leave the body at that spot to allow for healing for the rest of it. And it might be a couple months later, then they'll, turn that back into the colon, sew it up, and then hopefully they'll see that everything's working again. And then the sigmoid colostomy, they might actually just go in and like sever it and then take that pooch and bring it out through the skin so that they can poop out of that. And that's called a Hartman's pouch. They'll still have some poop or some mucus come out of their bottom, but it starts to dry up eventually. So assessment of an ostomy, remember we want it to be pink or red. We want it to be bright, shiny. We love it. We don't want them to have pain there. A little bit of bleeding is expected, especially initially. Or if you're cleaning the area, you see a little blood on the tissue, that's okay. That's the tissues, the internal intestinal cells are supposed to be doing that, right? So even though we're bringing it out of the body, we have some expectation that they'll still be functioning correctly. An abnormal ostomy would be that pale, bluish, dusky looking color. It's like not even out and proud. It's like all, sunken in. It hurts. Maybe it's bleeding a lot, not just dabs of like a little bit of blood, but like bleeding, and maybe even separates from the skin. And the care of the stoma, you might end up doing some teaching around this, but definitely wound will start off the teaching, and then you as a nurse will just sort of reinforce it. Skin care to the area, putting that Cavalon around the stoma so that when you stick the appliance to them, their skin is protected by the Cavalon. So if you don't know what Cavalon is, look it up. You need to get a good seal so that any poop doesn't go inside and then irritate the skin. You want to get the proper appliance with it, whether it's going to be a 2-piece or 1-piece. You're going to tell them how to schedule, when to empty it, all that stuff. And just so you guys also know, if you see your patient's bag getting filled with gas, but not poop, you should still empty it, okay? And yeah, you're going to want to probably put a little lavender scented something in your mask. Go in there and decompress that bag for your patient if they are not doing it. And teach them this will make your bag pop off or burst, and you don't want that to happen. So if you see this happening, this is essentially like a fart and you need to let it go. And so you might need to open it and release that pressure of the gas that's collecting inside the bag. Odor control, I was totally kidding. Do not put a Christmas tree in there. The Christmas tree aromatherapy thing. Odor control can be done with like sprays. Maybe you could even get like little strips of things that smell good and put them around, or even on the bag, on the outside of the bag. I mean, there must be ways that people manage this, but for the most part, people figure out dietarily how to manage odors, and so they can do it that way. And then also irrigate it if you need to, like spray it with a little bit of normal saline if you need to. And then at home, this is an important slide. Psychological support around having this appliance, having to take care of your body this way, seeing your poop in front of you instead of behind you in the toilet. You might make sure that they have any kind of referrals they need for support groups, chemotherapy support groups, stoma support groups. Make sure they're going to their appointments and make sure you're reinforcing wound management and stoma care with them. Remember, referrals are so easy. Okay, I hope you guys enjoyed this lovely discussion. If you didn't already look it up, look up the Bristol stool chart. It's awesome. There are coffee mugs that have it written on it. If you want to take that to school with you, I'm all for it. All right, have a good one.